If you look at the data, there's 100+ million women that have hormone problems. They have brain fog, they have hot flashes, they have decreased sexual drive, but they're the silent majority.
How have you developed this algorithm to make the landscape of women's care different? Why would a woman come in feeling exhausted? You draw her labs, her testosterone's in the toilet.
Testosterone is the dominant hormone in women. And women look at me with big eyes and say, testosterone, isn't that a man's hormone? Yes, it is, but it's also a woman's hormone. In fact, it should be the dominant hormone. You don't need to worry about growing up. Your husband over here is 1100, you're at 150 to 250. You're not going to have problems.
What about some other just more mild symptoms? That just because their dosing isn't right?
Yes, and maybe. Okay, so let me answer it this way.
What could she maybe do if she doesn't want to go on hormone replacement therapy yet?
99.999% of our patients are low in vitamin. 3 things can help you age healthier.
So I'm here with Dr. Boyd of Epiphany Women's Health, and we're going to dive into obstetrics, gynecology, where it's been, where it's at currently, kind of where we want to see it going in the future, what the landscape looks like for women that need care. So Dr. Boyd, just talk a little bit about obstetrics and gynecology, your training, your journey through it, and where we're at with women's care right now.
So it's interesting. I finished training in 1993, and I was a full-blown obstetrician gynecologist. But obstetrics ran the show for the first part of my career, and after I'd been out about 7 or 8 years, I picked up the gynecology and became very prolific in gynecology. I was an early adopter of robotic surgery, and I dove right into robotic hysterectomies, and it changed women's landscape dramatically. So I did that for 20 plus years, and I was in Peoria, Illinois at that time. I had finished training there in 1993, and when I finished training, a doctor that was close to, in fact, he let me do my very first C-section as a first-year resident in August, and I had started residency in July, so it was a big deal. So when Dr. Harmon called me and said, hey, I want you to take over my practice, I said, yes, sir. And even though I was from the South and my wife was from the South, we ended up staying in the Peoria, Illinois area. Initially, we thought it would be maybe 10 years, and that turned into 20. And then finally, after 20 plus years, I decided to close my practice and move to Pensacola, Florida. I was in Pensacola, Florida for several years, and then I decided to become a traveling physician. And as I traveled around the southeastern United States doing travel medicine, which is very interesting, you go into an institution and you're really just doing obstetrics, so high-risk obstetrics for patients that oftentimes don't have care. So I've kind of done everything. I've been a full-blown OB GYN. I've been a robotic surgeon with concentration on gynecology, and then I had nurse practitioners and a midwife that did a lot of the obstetrics. And then I got into the travel medicine, and I was the guy in a lot of these institutions that took care of all these high-risk situations. But I was sitting at a restaurant called Epiphany Farm to Table in Bloomington, Illinois, and I had an epiphany. I wanted to do a different job of taking care of patients than I had done in my OB-GYN world. In my OB-GYN world, it was all about volume. You saw 60, 70 patients a day maybe. It was shotgun medicine. You went in and took care of the problem. Hey, I'll see you next time. And so you didn't have time to look at the entire person, meaning the woman, from head to toe. Epiphany's different. So I wanted to concentrate on the woman with hormone problems, woman with stress incontinence, sexual function issues, abnormal uterine bleeding, and well woman. Those 5 topics define Epiphany. And under this umbrella, we want to be proactive with our patients. We want to be a functional medicine approach. So you look at lifestyle, diet, and activity, and all things considered as far as managing this patient. If you look at the data, there's 100+ million women, 100 million women that have hormone problems. That's a large number of women. But they're the silent majority. They have hormone problems, i.e. they have brain fog, they have hot flashes, they have decreased sexual drive. And who do you go see? Well, if you go to the OB-GYN world, a lot of those practices are heavy in obstetrics and they really don't have time for you. If you go to your family doctor, he for sure doesn't want to take care of you because he's managing his hypertensive patients, his diabetic patients. So guess what? You get patted on the leg and you say, this is part of life. And many women have had that exact scenario. This is part of getting older. This is part of life. It is. But so is getting pneumonia or getting strep throat. That can be part of life too. But you just don't pat the patient on the leg and say, well, you've got pneumonia, you've got strep throat, it's part of life. No. As a clinician, we treat them. We treat them with antibiotics and we watch them and make sure they get better. Why aren't we doing that with women that have all these issues? So 100 million women potentially have attention deficit needs that are not being met. It's kind of an interesting statement, attention deficit. But the attention deficit is from the provider, whether it's the OB GYN, whether it's the family doctor, whether it's the internist, or whether it's the nurse practitioner. And so Epiphany's model is to look at the entire woman, head to toe, have a proactive, symbiotic relationship with the patient. And in fact, one of the things that I do in my practice, I provide a lot of education. In fact, I frequently will say to a patient, hey, pull out your phone, go to your Amazon account. Everybody has it, so it's kind of comical when I ask that. But I've had 2 patients that have not had Amazon accounts, and I look at them, and one lady says to me just the other day, yeah, but my husband has one, so we can get it ordered. And so what I'd say to that patient, hey, I want you to order 2 books, and I'll give him 2 books. And then maybe a different visit, I'll say, hey, I want you to read a 3rd book. Now, not everybody likes this. In fact, my wife has said, you may be providing too much information for these patients, and it stresses them out. There are different patients for sure that have different needs. My opinion on the entire medical system is this, that 80% of patients are happy with traditional medicine, and then 20% of patients like this functional medicine approach and want to be involved in their care. And as we move forward, I think that's what you're going to see. I think you're going to see this 80-20 split, and the patients that are part of the traditional medical system are going to continue to get sicker and sicker and sicker. And hopefully the patients that are on this 20% ride will stay healthy. One of the books that I recommend is Gary Donovan's Age Healthier, Live Happier. Think about that title, Age Healthier, Live Happier. From age 50 and above, all people have chronic disease that starts. And as it starts, they develop problems, diabetes, hypertension, thyroid problems. And guess what traditional medicine does for them? They don't look at the root cause. They just treat the symptoms. Here, ma'am, you have hypothyroidism. Take Synthroid, and that will correct it. But why does she have hypothyroidism? That's not asked. Mm-hmm. And so traditional medicine is just, in my opinion, more of a Band-Aid effect. It's not a cause and effect. And so at Epiphany, we try very hard to find out the causative reason for your problem, correct it, and keep you healthy. Very interesting. I've been on both sides. I've been the traditional medicine doctor that saw thousands and thousands of patients, and I did that shotgun approach. Now I'm in a different model. And the Epiphany model is very interesting because there's a doctor overseer, which is myself, and then we have nurse practitioners that see the majority of our patients. And as we grow our company from 1 office to 2 offices to 3 offices, et cetera, every nurse practitioner is going to be giving the patient the same algorithm conversation that we're talking about right now. Patients get frustrated because they go to an office. If there's partners, one partner may give a patient one answer and another partner give the patient another answer. And what's the patient to do? Flip a coin and say, I'm going to go with Dr. Jones or Dr. Smith. You just don't know. We don't want to have that. We want our nurse practitioners, whether in Illinois or Alabama or Florida, telling the patient the same thing. And medicine's not black and white. There's a lot of gray, but we want to be fairly consistent in what we tell the patient.
So going back to your training in obstetrics and gynecology and where it was in the late 80s and then 90s. How do you see where you're at now? Like, when did it change? What was the process of taking care of these women? If you were in primarily an obstetric run practice, when did you kind of start to change to where you are now, where you're mostly focused on the gynecology side of things, which I think, we call it gynecology, but we could just call it, like you do, women's health, because if a woman's not pregnant, all of her health is kind of encapsulated in what she needs. It's not just gynecology. And so when through that, you were trained in a conventional manner, and then you were in the obstetric world, and you kind of started blending with your nurse practitioners. And so when did you see that change for yourself, and how are you going to continue to help your nurse practitioners be in that same way of treating patients?
I think that's a fantastic question, because our algorithm for our company is I have specific ideas that are mine, but they're based on information that I have learned as I become a functional medicine doctor. Functional medicine uses science just like traditional medicine does. But again, they try to find the causative reason for why people are sick and then move them forward accordingly. So if you go back to my early career, I finished training in a traditional allopathic program. It is interesting. I have 2 degrees. I'm a DO, which stands for Doctor of Osteopathic Medicine, and I'm also an MD, a medical doctor. So I have both degrees, and so I have a kind of a two-way approach that I look at patients. Osteopathic medicine, basically in a nutshell, identifies that the human body has an inherent ability to heal itself. And so if you correct various problems in our life, something as simple as drinking good water, maybe you don't have leaky gut syndrome, then maybe you don't have Hashimoto's. So you can follow that thought process. That is a holistic approach or an osteopathic medicine approach, which is different, oftentimes different than medical doctors. Now, there's significant overlap, so I don't want you to think that they're significantly different. But I have 2 degrees. When I finished training, I started my OB GYN career, and within several years, I decided that a nurse midwife made a lot of sense for a solo obstetrician. So I hired a nurse practitioner, a nurse midwife. She was fantastic. But she brought her own thought processes to our office. Perfect example. When she delivered a baby, she kept the bed of the patient intact at the time of delivery, instead of breaking the bed down and putting the woman in stirrups like the traditional obstetrician does. Guess what? I adopted that because it made sense. Why take the bed apart if you have to put it back together? And so that was a simple approach. And so I identified early on that nurse practitioners and nurse midwives bring a lot of positive to any medical practice. They think differently because they're trained differently, and that is a good thing. So after my midwife was hired, I subsequently hired nurse practitioners. And in the mid-2007-8 range, I had 4 nurse practitioners and 1 nurse midwife that were part of my practice. And so I early on realized that patient positivity rates for those practitioners were higher than mine. In other words, patients like nurse practitioners better than they like doctors. Now, why is that? Because nurse practitioners in their initial training are caregivers. They're nurses, which spend 99% of the time taking care of a patient. The doctors come in for 1%, if that much. We get all the glory, but the nurses do all the work. And so when you look at a nurse practitioner or a nurse midwife, they care about the patient as much as the doctor does, but they care about the patient in a way that the patient feels like they're being taken care of. So if you look at nurse practitioner statistics, 70 to 80% of patients have a positive thought process about their nurse practitioner. Doctors, we're down around 30 or 40%. So patients like their nurse practitioners double of what they do with their doctors. Mm-hmm. So why not take that information and those statistics and make that about the collective process of taking care of patients? Now, nurse practitioners don't have the education I do. It took me 12 years to finish my med school, my residency, college med school and residency. It takes a nurse practitioner 6 years. So it's double the training. So you need, in my opinion, you need a physician overseer to help direct nurse practitioners. But again, nurse practitioners can do 80%, sometimes more than that, of what a doctor can. So in the Epiphany model, we have this algorithm where nurse practitioners are providing care for the patient based on the feedback from them, but driven by me. And we hope that that care is complete and total for the patient.
So we've gotten to this place where, like you said, people are getting sicker and sicker, and most of the doctors are either OBGYNs that are focusing on obstetrics, or the primary care provider doesn't care about the hormone issues, and then maybe even an endocrinologist is just going to take care of maybe diabetes, but they don't really care about the other hormones. And so how have you developed this algorithm to make the landscape of women's care different, and what does that look like for them?
That was part of my epiphany. I've known, obviously, that hormones are important for women for my entire career, but it has received very little attention. For my entire career, I know that women have hypothyroidism. 40% of women have hypothyroidism after the age of 40. And I would see those women, I would test them for it, but I never tested for hormones to speak of. I never tested for thyroid antibodies, called TPO, that looks for diagnosis Hashimoto's. And so even though it was part of my overall care, it was part of my overall care in a very small manner, because I was interested in taking care of the obstetrical patients. I was interested in taking care of the woman that was bleeding and moving toward robotic hysterectomy. And so all of this other stuff, all of these very important issues that women have, really were on the back burner. And it wasn't just in the Boyd OB/GYN world. That's the way it is in every single OB/GYN practice to speak of in general, and every family practice office in general. So, hormones. There is so much controversy and so much misinformation. And we can go back to a very specific point in time where all of this crashed and burned and became a huge problem for women. In the 90s, there was a study called the Women's Health Initiative. And I believe the number was about 200,000 nurses were undergoing a study for hormones to identify if there's risks associated with hormones, specifically heart disease, specifically strokes, specifically breast cancer. And what they identified was that after X amount of time, there was an increase in those three things: strokes, heart attacks, and breast cancer. And so the study was stopped at that point because they were concerned that they were causing harm to these nurses. So in 2001, 2002, the study was stopped, and there was an ultimatum, basically in all of medicine, that you need to stop hormones for all women, for sure, after they've used it for 5.2 years. But, if a little is good, a lot's better. So most OB/GYNs, most family doctors, they didn't even allow the patient to go to 5.2 years. They just said when a woman was going through menopause, maybe I'll treat you for a couple months, but then we need to stop because you, ma'am, are at increased risk for strokes, heart attacks, and breast cancer. Well, breast cancer is the greatest fear that women have. So it's a very easy sell to women. If you take this, you're going to get breast cancer. So that was the study, that was the information, that was embedded in all of medicine. It's been contradicted many times since then, that it was a very poorly run study. The Pellet trial in 2007 contradicted what the Women's Health Initiative did, but did it change the landscape in the way providers provided hormonal care for women? The answer is no. In 2018, JAMA, Journal of American Medical Association, stated that after 18 years of use, women did not have an increase in strokes, breast cancer, and heart attacks. Menopause.org has stated that women probably should be on hormones for life. Now, why do they use the word probably? Well, it's a legal issue, right? So if a woman gets breast cancer after she's taken hormones, and menopause.org says women should be on hormones for life, they don't want to get lassoed into a corner. So they use that terminology. And there's other studies. In the functional medicine world, we feel very, very confident that hormones do not cause cancer. One of the books out there by a world-renowned oncologist called Estrogen Matters, he contradicts that estrogen causes breast cancer. But yet, if you look at the landscape of medicine, you cannot get hormones from many, many providers. And if you do get hormones, it's for a short period of time. And if you do get hormones, they use synthetic oftentimes versus bioidentical. And again, Epiphany does all of this very different, just like the functional medicine world does. When I was creating Epiphany, I became very interested in bioidentical. And I had given bioidentical all the way back to 2005. I had a friend call me. He was opening up a compound pharmacy. Women were not taking Premarin anymore. Premarin's interesting. That was a drug that was given to your grandmother and your great-grandmother. And for 50 years, women took Premarin. Premarin came from a pregnant horse's urine. So we have a horse, have him pee in a trough, collect the urine, or a pregnant horse, by the way, pee in a trough, collect the urine, extract the estrogen, put it in pill form, and that was called Premarin, and millions of women were on it. When the Women's Health Initiative came out, they stopped it. So millions of women were feeling great, and then a year later, they were feeling horrible, okay? So in 2005, when some of the literature was coming out that maybe the Women's Health Initiative is not correct, bioidentical pharmacies started popping up around the country. Bioidentical means the hormone is created in the same fashion that God created your estrogen, your testosterone, your progesterone. So it became very positive for a lot of women that they were going to take a bioidentical hormone instead of a synthetic hormone, okay? So I became very interested in the bioidentical, and I gave them for years and years, but the dosing was not specific. It was a guesswork. So you would come into my office, you said, I'm having hot flashes, and I would say, okay, I'm going to put you on this bioidentical. I want you to take a dime's worth, put it on your thigh, and massage it in. Now you think about that. If I say put a dime's worth of toothpaste on your toothbrush, how do you get a dime size? Some days you get a nickel, some days you get, well, what's less than a dime? I don't know, a smaller coin. Mm-hmm. And so it was not very exact. Plus, we didn't do hormones. We just simply said, hey, you're having hot flashes, take estrogen. Hey, you're having decreased sexual function, take testosterone. So is there a better way? And so as I was investigating this, I investigated the pellet world. Pellets are little tiny hormones, either testosterone or estrogen, that are placed right underneath your skin, and they provide a very steady state hormone approach for 3 months. People say, wow, that's new technology? And the answer is no. Pellets have been around since 1939. Johns Hopkins University. Women had surgical hysterectomies. They were feeling horrible. They were young women. And these OB GYNs, these gynecologists at Johns Hopkins investigated, talked to their pharmacist, and said, hey, can we give these ladies some estrogen? And so they did, and they provided them in pellet form. They inserted them underneath their skin, and voila, the pellet history was born. It predated anything oral by 20 plus years. The estrogen pills came out in the late 50s. And so when a woman says to me today, pellet therapy is new, no, it's been around longer than all other forms of hormones. The reason I like BioTe, though, specifically, BioTe, B-I-O-T-E, is because it's molecularly identical, bioidentical. So I like to use Elon Musk's spaceship docking at the space station. It has to be perfect, right? His spaceship comes in and binds to the spaceship exactly. It can't be off a little bit, because how can you get the astronauts from one place to another? Well, that's kind of like BioTe. It's bioidentical, molecularly identical. And so when it's floating through your body, it's going to look for the receptor, and it's going to bind exactly like it should.
And can you describe how that's different from a synthetic form that they've tried to make kind of like our molecules in our body?
This is the big argument from clinical medicine versus the biochemist, right? The biochemist says, I can make that in the lab, and it's exactly like the bioidentical. And I'm going to say, well, that's wrong. That's incorrect. You may say that it's structurally the same, but how it works clinically is not the same. Women do not feel as good on a synthetic hormone as they do on a bioidentical. A purist, a biochemist, may say, well, that's placebo effect. I disagree. And even if it is placebo effect, every single double-blinded study uses a placebo effect, or uses a placebo. And in the placebo group, you will see people that will say, yes, I feel better on this drug, whatever the drug is. And obviously, if the drug's a great drug, there's going to be a lot more people that feel better on the drug. But the point is, the placebo group always has a positive because they think that the medicine is going to make them feel better. So medicine is much more than just looking at a chemically structured compound and saying, this is biochemically the same. It's not.
Because you're saying all the side effects are the bad side. So like a placebo is going to make you feel good, but they're not going to complain of bad side effects. Whereas the synthetic comes in and all these women are having side effects from the synthetic, whereas they weren't with the bioidentical.
That is what I see. And so there's two parts. Number one, it doesn't work as well. Okay. So women state that they do not feel as well on a synthetic drug as they do on a bioidentical. That's number one. Number two, the side effect panel is going to be greater. Why is that? Because they lace it with entities in the lab to make it in pill form or in a cream. So it's binding agents for the hormone. So when you ingest those, that's going to be different than the binding agents of a bioidentical agent.
And is it also that they don't have as good of targeting to the receptor as a bioidentical? So a bioidentical is only going to bind to the receptor that it's supposed to, just
That's
like
correct.
our normal, our hormones that are released in our body, whereas a synthetic form could bind to receptors that maybe weren't meant for that hormone.
Well, that may be true. I don't think that's correct, though. I think, but here's what I think structurally you see in the clinical world. So you ingest the hormone. So first of all, there's only three possibilities that you can use a synthetic version. Okay. Number one is oral. Number two is a patch, or number three is a shot. Okay. All of those are synthetic, and all of those have problems based on the way that they're given. So the patch, for example, how much is ingested through the skin into your body? Now, you can do you can do testing analysis of that hormone patch and identify what the patient's estrogen is at a certain level. But to be purely accurate, you would have to do an estrogen level every single day at the same time to determine if they're up or down, up or down. Now, we already know the answer. They're going to be all over the place, okay? So they're going to be all over the place. Why? One argument is because it did not get absorbed into the skin very well. That's one possibility. The other possibility is that there's not a good receptor for that synthetic hormone to bind to. In other words, the body's receptor, is there something that says, I'm not going to bind you because you're synthetic? You're not a biochemical agent, okay? And so the patient therefore feels bad. The same application occurs with a shot. So I have patients that take testosterone injections. It's synthetic. It's not bioidentical. And some patients say they feel okay, but it's kind of what they're after. No, again, they're going to get placebo effect just like the bioidenticals. If they want to feel better, they're going to feel better. But do they feel as good as they would if they were taking a bioidentical? And my clinical experience is they do not.
What do you, from a functional medicine side, you have someone come in and they want hormones or they want something to make them feel better right now. But from your functional medicine side, what else do you do to help that person, maybe without going straight to the hormones, other things that can help them feel better instead of just always going to an immediate fix?
Well, your question's interesting because the fix is part of trying to identify, first of all, what is going on with the patient when they come through the door. So I have discussions with patients after they've talked to Dr. Google frequently. So we have this vast amount of information on the World Wide Web. And so I jokingly call it Dr. Google, because patients, when they have symptoms, when they have things that they're concerned about, pull out their phone and identify a question to Dr. Google, and then they get a host of answers. The problem is there's so much information out there, it's information overload. And so I frequently tell patients it's like going to the wallpaper store or the paint store. After you've looked at 20 or 30 or 40 whites, how do we decide which white I want to put on my wall? And you think, oh my word, I need to leave. So patients come in oftentimes with that information overload. And so you have to step back as the provider and truly try to understand why the patient is here. Again, looking at the whole person. So again, functional medicine is lifestyle, diet, and activity. So the context to your question. So we look at lifestyle. What is going on? So are you having brain fog? Are you having decreased energy? You used to run and now you don't run. You used to lift weights. You used to play tennis. Now you're not. Why? Well, and most people can figure it out, and it's usually an age-related phenomenon. And I mean, you're a mother. You've got lots of children. It makes sense, but you still know your fatigue level at the end of the day. At 8 o'clock at night, I'm tired because I've been taking care of my children all day. But what happens if you wake up in a year and your fatigue is way, way down there, and your life with your children, your household has stayed the same? Something's different. Well, how do we identify that? Well, that's this conversation right here. So that's the lifestyle. Diet. We know without a doubt that your gut is 99% overloaded with junk based on toxins, heavy metals, and antibiotics that come through your gut, either through your water or through your food. Just go to your EPA, go to your hometown, and do an EPA analysis of your water. I live in Fairhope, Alabama. There's 16 toxins in our water here that are acceptable. 6 of them are above the threshold of cancer, but are acceptable on EPA standards. So we have an entire whole house water filter system, and we have reverse osmosis in our kitchen. I want to reduce the toxins. I want to reduce the heavy metals. I want to reduce the antibiotics. So that it plays into how we fix you, whatever your symptoms are. And then the third part is, back to my lifestyle, the other part of that is trying to reduce your stress load. If you're in a crazy job, I traveled 140 times one year on an airplane when I was doing this travel medicine. It's pretty stressful. I like to fly, but it was still pretty stressful. So if I felt stressed, somebody may say, well, maybe you should be on the plane 140 times. But somebody's got to bring that up. Oftentimes it's an outsider that identifies that. And then the other part of lifestyle is sleep. We know without a doubt your brain needs to reset. What's the magic number for hours of sleep? It's a little bit different from everybody. But for men, it's around 7 to 8 hours of consistent sleep. And for women, it's more than that. It's 8 to 9. So if all of a sudden you're 45 years old and you're not sleeping well, and you go to a family doctor, oftentimes they'll say, well, you must be depressed. And you get put on an antidepressant. And nobody ever thinks or talks about, I shouldn't use the word nobody, many practices never say to a woman, I wonder if we check your hormones, if your hormones are out of whack, maybe that's our problem. And so that would be a scenario, again, where you're talking to the patient and trying to figure out what's going on. The third part is activity. Now, interesting word about activity. As an athlete, I love to go to the gym. I love to ride my bike. But my wife doesn't. She likes to garden, and she likes to be outside, and she likes to camp. Activity, right? So it's not like you have to be in the gym, on the treadmill, lifting weights. Activity means your body's moving. And the interesting thing is they've looked at this with older people. 3 things can help you age healthier: lifestyle, diet, and activity. Functional medicine. So lifestyle, you have sleep that we talked about. Lifestyle, diet, you try to get whole foods in your diet. And activity. The interesting thing is you can increase your age by up to 5 years by being active 35 minutes per week. That's 5 minutes a day. And you say, well, everybody does that. No. Oftentimes patients retire, and then they retire. And then they go to so they get up in the morning, and they go to their chair, and they stay in their chair all day long, and then they go back to bed. And so 5 minutes a day can increase your longevity. But it's not just increasing your longevity. We want you to be healthy as you age.
So I want to go back to the diet part of this in relation to hormones. So as women, we know menopause. Most women know that, okay, I'm not releasing eggs anymore. My estrogen's decreasing, but you haven't talked a lot about testosterone. And specifically for women that maybe aren't in menopause yet, why would a woman come in feeling exhausted? You draw her labs, her testosterone's in the toilet. What could she maybe do if she doesn't want to go on hormone replacement therapy yet? Is there something that she can do to get her testosterone up? Is it possible?
So trying to understand. So first of all, we have to have baseline understanding of what hormones are. So women produce 3 hormones: estrogen, progesterone, and testosterone. Now, I started with estrogen because in my entire career as an OB/GYN, estrogen has been, in my mind, the predominant hormone for women. So then I get into the functional medicine world and I identify that it's not estrogen that should be or is the dominant hormone in women. It's testosterone. And so I have been educated, and it's amazing. I've been out 30 years. I went to college, med school, residency, and I realized 30 years after my career that testosterone is the dominant hormone in women. And women look at me with big eyes and say, testosterone, isn't that a man's hormone? Yes, it is. But it's also a woman's hormone. In fact, it should be the dominant hormone. Great story. So a woman's 25 years old. She has all kinds of energy. She's been recently married. She has sex every night. Life is great. If you look at her testosterone when she's 25 in that scenario, it can be up to 25 times higher than her estrogen. Never, I hate to use words like never, but I'm going to say never does that woman sit in her chair at night after she's had sex or her bed and say, oh my gosh, I've got too much testosterone because I'm having sex every night. I have all kinds of energy. I can lift weights. I'm scared I'm going to grow a beard, grow a deep voice, and grow a penis. Never does she think that way. And then she goes 20 years into the future, and she comes into my office, and I said, okay, let's talk about testosterone. You're in your 40s. We're going to do some blood work, but we're specifically going to talk about testosterone. And she gets big eyes, and she gets, whoa, testosterone, isn't that a man's hormone? And immediately in her mind, she's going to grow a beard, get a deep voice, and grow a penis. I said, no. Let's talk about testosterone. So let's talk about these 3 hormones. So as you go into your reproductive life, you're made for one reason, to have babies. And again, that's not a sexist statement. That's the biology. In fact, if you don't have babies, our Earth goes away in 1 generation, right? So biologically, you're made to have babies. So you have an estrogen that needs to produce an egg, then you ovulate, and then you have a decrease in your estrogen, then you have an elevated progesterone that keeps the baby alive until the placenta takes over at about the 8th week. But what about testosterone in that role? Well, testosterone is kind of important for driving the experience, okay? If I remove your testosterone, maybe you have sex, but maybe you're not interested in it at all. And so you need testosterone. You also need testosterone for your muscles and for your spine. And it's very important in your brain. And so you need all 3. And so nobody really talks about that. And then you move forward in your life, and now you're 30 or 35 or 40, and all of a sudden you have brain fog, and you have no energy, and you have fatigue. Back to you have children, and all of a sudden your fatigue is dramatically lower than it was a year ago, and you have the same number of children. Why am I so fatigued? So we draw a panel of labs at that point. So again, I've listened to your history. I have an idea what's going on. We've talked about your diet, your activity, your sleep, and try to make sure that we're identifying all the functional medicine aspects of it. And then we get a panel of labs, and we call them the Well Woman Labs. I love that name. And it's a CBC, so it's a complete blood count. So we know, hey, are you anemic because you're 40 years old and you're having crazy uterine bleeding? We do a metabolic profile. I need to make sure that your sodium, your potassium, your liver enzymes are fine. Make sure your blood sugar is not elevated. I check your ferritin. That tells me if there's inflammation in your body and how well your bone marrow is working. I check your complete thyroid panel. So this is a transparent statement here. In my entire career, never did I order a thyroid antibody until a year and a half ago. I don't know why I did, but we're not educated that way. We're educated that you check a TSH and a free T4, and then we diagnose hypothyroidism in women, and we put them on Synthroid. That's the standard treatment across the country. So in the functional medicine world, hey, no, you need to do a whole panel. So TSH, free T4, free T3, and a TPO. And then we also check a vitamin D. 99.999% of our patients are low in vitamin D. Now, I want to talk about vitamin D because vitamin D is, when the value comes back, it's on a range, and every lab has a range. So vitamin D is normal range from 30 to 100. And so I had a patient today, she was 31. I also had another patient today, she was 14. So many doctors would say, okay, the patient with 31, you're a normal range, you're fine. The patient with 14, well, you're a little bit low. So take 1,000 international units, maybe 2,000 international units of vitamin D, and let's try to get you up. But they don't recheck it. And vitamin D goes up very slowly. And they don't talk about being out in the sun because it's hours of UV radiation. That's a trivia question. What's the only vitamin that you make? Vitamin D, right? And how do you make it? Sitting out in the sun.
Or eating a lot of cholesterol.
Yes. So we check a vitamin D. 99.999% of our patients are low. And that's just not our patients. That's everywhere in the world. And then a B12 level. And we, again, use optimal levels. And 95%, probably 98% of all of our patients are suboptimal in B12. And then we check a testosterone level and a free testosterone level, an estrogen level, specifically estradiol. There's 3 estrogens, E1, E2, and E3. We check E2, which is estradiol, and then we check an FSH to identify where you are in the menopause state. And then I have you come back, and we go over all of these. And this would be a classic scenario. Okay, McKenzie, I'm going to go over your labs. Now, you're 32 years old, and I would expect your CBC to be normal, unless you have crazy heavy bleeding. If you have heavy, crazy bleeding, then we need to investigate, because as a 32-year-old, what's the most logical explanation? Uterine bleeding. So we would get a further history. Hey, are your periods heavy? Now, for you, they may be completely normal. I've always had this. So it's not out of the ordinary for you, but your anemia shows different. So we would do an ultrasound on you and then talk to you about uterine ablation if you're done having babies, okay? Then we check your metabolic, we'll go over your metabolic profile. You're slender, so I don't expect you to have diabetes, but if you had an elevated blood sugar, then I would do a fasting blood sugar, and then I would do a hemoglobin A1C, okay? I then move into the vitamin D. So vitamin D, again, 99.99% of our patients are low, and I'm going to recommend that you spend more time out in the sun and that you take, again, I'm going to use both of these examples on these patients. The patient with 31, I'm going to have her take vitamin A, vitamin D, and vitamin K. The vitamin D I'm going to give her is 10,000 international units. So we have BioTe has a nutraceutical called ADK10, and I'm going to put her on ADK10, have her take it every night, and then I'm going to recheck her value in 3 months. Because remember, it's a slow rise. The patient that was 14 today, I'm going to put her on 20,000 international units of vitamin D. So I'll have her take an ADK10 from BioTe, and then I'll have her take another vitamin D that she can buy from Amazon. On B12, I do two things. So value today, 486. I want the patient to be 1,200. And again, the range, I want to be optimal. When you're sitting there talking to a patient and you tell a patient that they're fine with 486 on their B12, I would say back to the doctor, well, fine didn't get you into medical school, right? If you had C averages, which is the bell-shaped curve, that means 80% of the population fall in there, you would be fine. You'd be a C student. Well, you would have never gone to medical school. You had to be optimal. So why aren't we educating our patients to be optimal? And so B12, I would want you in optimal range. It's very hard to get your B12 up. You've got to eat animal products, livers, hearts. People aren't going to do that. So we give B12 injections. Interesting story. My father, 50 years ago, when a woman was going into menopause, or a man, every person over the age of 60 got B12 injections every single month. Now, they didn't do blood work. They just knew that what people needed B12. So in the morning, he'd have 10 patients lined up, boom, 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 give them all their B12, see you next month. Charge $3 for that. A lot more expensive than today. But we give B12 injections. Some patients come in every single month, but I also give prescriptions. I give a 10 cc vial. You take 1 cc every month. And if you feel comfortable giving it or having a family member giving it, then we give B12. And again, we want the optimal range. I also recommend a B complex vitamin. The interesting thing about B vitamins, there's 8 of them. And it's so weird. So if there's 8 of them, how do we get to 12? Well, there's 1, 2, 3. You skip skip 4 and 5. There's 6, 7, and 8. You skip 9 and 9. And there's 10 and 12.
9 and 12.
9 and 12. See, it's hard to eat.
It's hard to
remember.
of, yeah.
There's 8 B vitamins, so it's easier to get a B complex vitamin. B1 is very important in converting your thyroid 4 hormone to thyroid 3, which goes to your body, your cell, and does its work. Synthroid is a T4 drug. We assume that when we take Synthroid for hypothyroidism, that it converts from T4 to T3 with this enzyme. This enzyme, though, needs B1 to help convert it. So what happens if you're low in B1? You don't get good conversion. So I'm taking this medicine, it's not getting converted to T3. T3 is not going to the cell, so it's not doing what it's supposed to do. So you're suboptimal in your care with that patient. Why not give the patient a T3 drug like Armour Thyroid? Well, that's a bioidentical type of product. It's a pig thyroid mashed down, put in pellet form, and then we give it to patients. But it's very infrequently used except in the functional medicine world. AP thyroid, Armour Thyroid, same thing. The number one prescribed drug in the entire world right now is Synthroid. Why do we have so much hypothyroidism? Again, cause and effect. And in my world, it goes back to leaky gut syndrome. That I'm coming to diverging here, so I'm down a rabbit trail. No, so back to my lab. So we do the 4-pronged thyroid panel, and then the last thing is we talk about your hormones, specifically your testosterone and your estrogen. What about progesterone? Remember, progesterone is only necessary to maintain an early pregnancy life. Okay, so after ovulation occurs, you either get pregnant or you don't. Okay. The progesterone goes up either way after ovulation. If you're pregnant, it stays elevated and maintains the pregnancy until the placenta takes over at about 8 weeks. If you did not get pregnant, then the progesterone level falls, and that causes a period. Now think about this. If you replace progesterone, I had a patient today that she has classic estrogen problems. She has vaginal dryness, pain with intercourse, and her provider, who's a hormone specialist, took her off estrogen. She was on testosterone. She kept her on testosterone, but she added progesterone. And her symptoms got worse. Why? Well, because progesterone does not improve the vaginal moisture. In fact, think about this. I keep bumping this. If you think about this. So a woman is happy about having sex. She's well lubricated vaginally at ovulation. After ovulation, estrogen falls, progesterone goes up. Biologically, she doesn't need to make a baby. So she's not interested. She has vaginal discomfort because of the progesterone effect. So progesterone is not necessary for hormone replacement therapy, except if you have a uterus. Why is that? Because if I give you estrogen and without progesterone, you increase your risk for uterine cancer. Now, I just said earlier that that hormones don't cause cancer. Specifically, I was talking about the breast. If I give you unopposed estrogen, you increase your risk for uterine cancer. Unopposed means there's no progesterone. So if I give testosterone and estrogen in pellet form, I add oral progesterone at nighttime to counteract the effect of the estrogen on the uterus. So back to my labs. Most of the patients that come through here are going to be low in testosterone. Now, interesting about testosterone and the range, okay? So again, this is an example of not listening to the patient. Patient comes in, I have no sex drive anymore. And so I check, if I'm one of the doctors that does check hormones, I check a testosterone, and your value comes back 14, okay? And he says, well, you're a little bit low, but you're fine, and oftentimes doesn't treat you. But let's go up a little bit. Let's say you're 30. So then you're falling within the range of normal. This is total testosterone. And he says to you, well, your testosterone's fine. Maybe you're depressed. So let's put you on an antidepressant, which makes sex drive fall even further. So why did he do that? What does the reference range mean? In the estrogen world, we have millions and millions of input data to determine where your estrogen should be because of all of infertility issues. We know that estrogen should be here in the first half of your cycle. It should be here when you ovulate. It should be here in the second half of your cycle. So millions of input data. But because we have thought that testosterone is a man's hormone, there's not millions and millions of data points for testosterone. And there's never been studies identifying that testosterone decreases at a faster linear rate than estrogen does as you age. So if you look at estrogen over time, as women age, it goes down like this. Testosterone goes down like this. So you're 45 years old, I'll go back to 35, decreased sex drive, your doctor says you're fine. But doctor, I just said I have a decreased sex drive. I love my husband. There's nothing stressful in my marriage. And he says, maybe you're depressed. That's why your sex drive goes down, instead of talking to you about testosterone. So what does the BioTe company and world recommend for testosterone? We recommend a total testosterone level between 150 and 250. Now, to kind of put things in perspective, when I do men's hormone pellets, because I also do men's hormone pellets, we recommend that a man be at a level of 1,100 to 1,200. So again, a woman's 150 to 250. So, ma'am, you don't need to worry about growing a penis, okay? Your husband over here is 1,100. He has a penis. You're at 150 to 250. You're not going to have problems. And a woman says, okay, let's move forward.
What about some other just more mild symptoms? Women grow a mustache, or I've heard their clitoris gets too big, or they do feel like their voice has deepened. Is that just because their dosing isn't right?
Yes, and maybe. Okay, so let me answer it this way. So BioTe, I love this company because they develop an algorithm for you specifically as a patient, okay? And so, again, assuming you're coming in and you have decreased sex drive as your symptoms, you're 35 years old, and so we obtain labs on you, and it identifies that you have a low testosterone, but you have a normal estrogen. So I bring you into the office, and I say, this is where you're at. You potentially can elevate your testosterone by increasing your muscle mass. So if you go to the gym and work on heavy weights, potentially your testosterone can go up and a lot of your symptoms will go away. So that would be a natural approach.
Okay. Is diet part of that too?
Well, yes, because if you look at diet, anything that potentially is inflammatory, and this is what's so interesting about testosterone. So if you have inflammation in your body, testosterone is a natural anti-inflammatory. So the question is, can you elevate your testosterone through diet? Some people say you can based on food that you eat, meats, etc. I don't necessarily agree with that. I don't think that you can increase testosterone through diet. But if you ask why do some women have lower testosterone than others, remember that all hormones are cholesterol based. People are shocked with this. So statins, the number 2 drug in the world, Lipitor, it was the number 1 drug forever and ever, but we give statins because of elevated cholesterol. Now, the interesting thing about that is the cholesterol, or the brain, is made up of 60% cholesterol. So I'm the doctor. I say to you, your cholesterol is elevated. I'm going to put you on a statin to lower your cholesterol. So I'm also lowering your cholesterol here to decrease the cholesterol in your heart. Now, why? So a functional medicine approach says, well, why do you have problems in your heart? The answer is because you have inflammation. So cholesterol is necessary to help the inflammation. So it goes to the heart to decrease the inflammation. Well, the inflammation is still coming on. We haven't identified the cause, right? Mm-hmm. And so that means more cholesterol comes to help decrease the inflammation. Now you have a plaque. And the cardiologist says, oh, you have a plaque. We need to give you Lipitor to lower your cholesterol so that you don't make a bigger plaque. So it's looking at this backwards. Mm-hmm. So back to your question about diet. So can you take things that increase your testosterone? The answer would be yes, a higher fat diet. Okay. Does it increase the overall total testosterone? Maybe. There's not really, to my knowledge, there's not really been studies that have looked at a high fat diet increasing your testosterone level. It makes sense because if I have a high cholesterol diet, and we know that the building block for testosterone is cholesterol, potentially that could increase the cholesterol, therefore your testosterone.
So then back to, so this woman comes in, she's 35, you finally draw her total testosterone and tell her, okay, this is what we're looking at. So what's the next step from there?
So I would say to her, okay, you're 35 and you have low testosterone. And she would say, well, does that mean I'm in menopause? Okay. No, it simply means you have a low testosterone, a low hormone level. And again, lifestyle, diet, and activity. Why do you have a low testosterone? And we would try to identify what in her body is low that she's not doing. So I'm going to look at you. You're a petite woman. You have a petite frame. If you increased your muscle mass by 20 or 30 or 40%, would you, as a 32-year-old woman, have an increased testosterone level? Maybe, maybe not. It makes sense from the biology standpoint, but I don't know. So I could set back to your question on this specific patient. Probably she's not going to change her life where she becomes Arnold Schwarzenegger, over the next year. She's just not going to do that. She may go to the gym and try to increase her muscle mass. But a logical approach, and I don't call it a fix-it because this is part of looking at the entire woman, it would make sense to say to the woman, you probably will feel better. You'll probably have more energy. You'll probably have improved sexual desire. You'll probably have less brain fog. Let's put you on testosterone. Now, I really only recommend 2 testosterone treatment options: bioidentical oral or bioidentical pellet. Now, if a woman says, I'm not doing any of that, I want a testosterone injection, I understand it's synthetic, I'm going to say, okay. I don't agree with that management, but I'm simply here to direct her. I'm not her boss. And I would never say I'm not giving you testosterone because it's synthetic. But I'm going to encourage her to do bioidentical troches. That's kind of a fancy way to take, and you put these little devices under your tongue, and they're absorbed into your bloodstream versus swallowing it. And so theoretically, the absorption's better with a troche. So I would talk to her about a bioidentical troche, or I would say, let's consider bioidentical pellets. Now, the pellets I love because of the steady state approach. When we insert these, so back to BioTe, so if you agree, okay, I'm going to do pellets. So then I take your data, your age, your weight, your lab values, and I input them into the BioTe algorithm, and it spits out a dose. And it says McKenzie needs X amount of testosterone. And I'll just give a number, 87.5 milligrams, okay? So that dose then becomes the dose for you. And so I bring you into the office, I have you sign a consent form giving me permission, and then I make a little stab incision, usually back on your buttocks. It's about this big, and I insert this tiny little pellet underneath your skin. In that pellet is enough testosterone to last you for 90 days. The science of this company is amazing. And so it's sitting right by a blood vessel. Every time your heart beats, and your heart beats about 80 times a minute, it picks up a little bit of hormone, a little bit of hormone, a little bit of hormone. So every day you have the same, theoretically, the same serum level that you had yesterday and you'll have tomorrow. And then at the 90-day mark, the pellet kind of runs out of juice, and then you come in and get pellets. And then we go to the other side. And we can continue this as long as you feel comfortable moving forward.
So to kind of switch gears, but it's still talking about Epiphany and everything you're doing, you mentioned all of the irregular bleeding, the heavy bleeding with women. So this is another huge topic for women that are not just focused on having babies anymore. So where are you at with Epiphany when it comes to how you manage and... It's okay. Yeah, a lot of talking. And what you recommend and what you provide as a service to women that are having abnormal uterine bleeding and really want to be done with it.
So it's very interesting. I'm a surgeon. I love surgery. And if I knew that it wasn't dangerous at all for patients, I would take every woman and surgeries her somehow. I love it. I've done thousands and thousands of surgeries in my career. I've done robotic hysterectomies. I've done 992. I really wanted to get to 1,000, but I didn't.
I hope this is not to say that you take people to surgery unnecessarily.
I do not. However, it's interesting. When I became a functional medicine doctor, you approach women differently than you did before. So in the United States, every single year, there's 700,000 hysterectomies done. Now you think about that, 365 days, that means almost 200 hysterectomies are done every single day, 7 days a week, 365 days in the per year in the United States. That's just the United States. How many of those women were offered another option before their hysterectomy? And I'm going to state that probably 50% of those women were not offered a more conservative approach, specifically uterine ablation. Okay, so let's kind of go through what a woman would expect if she had abnormal uterine bleeding. So a woman comes to me and she notices a change in her cycle. It's heavier, she's passing more clots. We do a blood count on her. She may or may not be anemic, but it's interfering with her life. Now think about this. If you bleed heavy for 3 days every single month, you extrapolate that over a year, that means 36 days a month. One solid month of your life, you feel like crap, you're changing tampons, and you say, why? I'm done having babies. But women live with this month after month, year after year after year. And if they say something to their doctor, which many women do not, but if they do say something to their doctor, oftentimes they will be offered a birth control pill option, or they'll be offered a hysterectomy. That's kind of it in a nutshell. But you have abnormal bleeding. It's a change from what you have had before. So you come to my office, we have this conversation, and I say, okay, let's get your labs and let's do an ultrasound. I do the ultrasound and I identify, do you have things in your uterus that are causing problems? Do you have fibroid tumors? Do you have a polyp inside your uterus? things that we can correct without taking your uterus out. Assuming that your uterus is not too big, meaning greater than 12 centimeters, that would be consistent with a woman that's about 3 months pregnant. If your uterus is less than 12 weeks pregnant in size, then you're a candidate for what's called a uterine ablation. Now, uterine ablation, that word ablation means that we're destroying the inside cavity of the uterus. Now, think about it. There's 3 ways that you can destroy tissue. You can cut it out, you can burn it out, or you can freeze it out. So for much of my career, the great majority really until the past year, I either did a hysterectomy or I did uterine ablation using heat. And I used a device called a NovaSure, which is a T-shaped device. It goes inside your uterus, it opens up, and it sends intense heat, intense current in a rotational pattern like this, and hopefully we've burned enough of your uterus that your bleeding will decrease. Now, the interesting thing is because it goes like this, it may miss the corner of your uterus, either this side or this side. So if you look at the statistics with uterine ablation using heat, specifically NovaSure, 70% of women get better. That means 30% don't. And women, like we all do, oftentimes look at the pot or at the glass half empty versus half full, right? And so a woman will say, well, if it fails 30% of the time, I don't want to mess with that. I just go to hysterectomy. And then you have a surgeon that loves surgery and says, fine, we'll take your uterus out. And so that's kind of the mechanism of why there's so many hysterectomies done in the United States. We at Epiphany approach this a little bit differently. So number one, I've changed devices. This past year, I've switched to a device called Cerené, Cerene. I like that name. You think about Cerené, you think, I kind of feel good. Well, it's kind of weird, but if you can stop bleeding and enjoy life, enjoy your husband, that's kind of a serene environment. What Cerené does is it uses intense cold. Now I live down in South Alabama. What people don't know about, if you freeze a digit and get frostbite, but if you go up north and go to Canada, people fall off their snowmobiles and they're drunk, and all of a sudden they have frostbite of their feet or their hands and they lose body parts. Well, the same application occurs inside the uterus. We put this device up in your uterus. It's a balloon. It cools to minus 140 degrees Fahrenheit. Minus 140. That number is just mind-boggling. For 150 seconds, that ice cube sits inside your uterus. And then after 150 seconds, we stop the procedure, we let the ice cube melt, we pull the device out. 90% of women, this was an FDA-approved device. They provided more data to the FDA than the heating companies did, like NovaSure. They had more people in their studies, and they identified that 90% of women have improved bleeding all the way to 0 and improvement of their pain. Remember, oftentimes women, when they have pain, they have contraction of their uterus. It's called dysmenorrhea. So not only do they have goofy bleeding, clots, etc., they also have pain with their bleeding. And so dysmenorrhea rates, painful period rates, also decrease by 90%. We do office-based surgery at Epiphany. I love this. Now, I've been doing office-based surgery. I did this with Boyd OB GYN, but we've made it a staple in the way we approach women. So I'm heading to my office in Illinois tomorrow. I have 4 patients that I'm going to do an ablation on. We're going to use the Cerené device. They come into the office, they sign a consent form, they get an IV started. We give them IV sedation using a drug called propofol, which is very, very safe. That's the drug Michael Jackson used to go to sleep. Unfortunately, he took too much because he didn't have somebody managing his airway. So we have an anesthetist, which is called a CRNA. He manages the patient's airway. We do the procedure. The patient's asleep approximately 7 minutes. We wake the patient up. We take them to our recovery room. We manage them for anywhere from 15 to 30 minutes. Their husband picks them up right outside the back door, and they go home. If they want to go to Waffle House 2 blocks away, they can. So they're here a total of about 1 hour and 15 minutes. Now, you think about going to the hospital. in the best scenario for uterine ablation, you're there about 6 hours. So you can go to the hospital and spend 6 hours, plus it's at least 5 times more expensive than it would be here in the office. You're here an hour to an hour and 15 minutes. Your only restriction is you can't drive, and we don't want you doing any type of hard work for 24 hours. After 24 hours, if you need to go to Alaska the next day, you can get on an airplane and go to Alaska. You would expect to have a lot of watery discharge because, again, you think about destruction of a tissue. It's like having a blister on your heel. That's called serous drainage. So when you get all that serous fluid and it collects in your uterus because your uterus is very inflamed because I've given 150 minus 140 degree temperature, you have all this inflammation, so you have all this watery discharge. And that watery discharge will be evident for about 7 to 14 days.
So I think women are loving having surgery in the office.
Absolutely.
I mean, going to the hospital is a terrible experience, and unless you want to get sick from something from the hospital, don't go, right?
Right, that's exactly
Just
right.
go if you're dying.
Yeah.
That's really the only time you should be going to the hospital. And so you providing this service to women when they're not sick, they're not dying, they just want to stop bleeding. And it, like you said, so many women don't talk to their providers about their bleeding because maybe they don't want major surgery, they don't want a hysterectomy, or they don't want to go to the hospital. And so, yeah, it's kind of kept women in this world, this middle ground where they don't want to be. And so with that in-office surgery, do you provide other services other than the ablation under in-office anesthesia?
Yeah, so we will use anesthesia for any procedure that we do for the patient. It is an extra fee because our Cerené works as a 1099 employee. He doesn't need to be hooked up with insurance companies. So it would be a $500 fee if you have surgery. And our procedures typically go to insurance if it's a uterine ablation. We have a patient that is a young person that's never had a baby. She's scared to death to have an intrauterine device placed. So she's going to pay the $500 anesthesia fee. We're going to put her to sleep. She'll be asleep for about 4 minutes. We dilate her cervix, slide the IUD up into her uterus, do an ultrasound before she wakes up. She wakes up and goes home. Women that need reconstruction of a loose vagina. So a woman's had big babies. She has a floppy vagina. It's called perineoplasty and vulvar or labial reconstruction. We do that here in the office. If a woman needs her bladder's falling down, it's called a cystocele repair or a bladder repair. We can tuck the bladder up. Again, we can do that in the office. The beautiful thing is we offer these services in concert with what the patient desires. Now, we also offer a couple of other, what I'm super excited about. It's called platelet-rich plasma, and women can do it without anesthesia or with anesthesia. Platelet-rich plasma is a technique where we replace your blood products back into your body to heal itself. So, quick history on platelet-rich plasma. PRP has been around for at least 15 years, maybe longer than that. There's 12,000 articles in PubMed. PubMed is the library of all studies that have ever been done all around the world. 12,000 articles on PRP in PubMed. So this is not new science. If you look at who started doing PRP first, it was the oral surgeons. So the oral surgeons identified if you had need for repair of a dry socket, for example, that they could inject platelet-rich plasma into this dry socket, create new tissue, and the dry socket would heal. The orthopedic doctors use it for placement in the joint to help regenerate collagen in the joint. The vascular guys use it for people that have poor circulation, like diabetics. In the genital space, we apply it in around the urethra, around the vagina for women that have stress incontinence. That means they cough, they sneeze, they laugh, and they pee, or women that have sexual function issues. They have inability or decreased orgasm. And so what is PRP? So you come into the office, we take blood out of your arm, and we spin it down in a centrifuge for 10 minutes. And it spins down into 3 layers in a tube. And then we take the top 2 layers and re-inject it back into your body. Now think about it. I'm taking your body and re-injecting it back into your body. So the risk for any type of problem is close to 0. So we inject back into the face for people that have acne or scarring or people that have wrinkles. So when we microneedle your face and then we inject PRP into your face, it tells your bone marrow, hey girls, wake up. We have an injury to this organ. You guys need to go and produce some new collagen. So in the face, you have this kind of enlargement of the face, so wrinkles naturally go away without having to inject Botox. Because remember, Botox is fine. It works great. But at what point do you go from working great to looking like you have a plastic face or you have duck lips? Okay. So the vampire face was created by a doctor right here in Fairhope, Alabama, Dr. Charles Runnels. It's a stupid name. We call it the vampire face, but you remember it. And so we're super excited about offering
sucking your
that.
blood.
That's right. That's right. But again, it's a completely natural process. In the genital space, it's called the O shot, the orgasm shot. And again, we use it for women that have stress incontinence or decreased sexual function. Most women, we do this under anesthesia using a topical cream and lidocaine. But 2 of my patients did not want to, they were scared to death to have a needle placed in their clitoris, so they went to sleep, back to my IV sedation. So I did one patient where we did her uterine ablation, and then following her uterine ablation while she was still asleep, I did her O shot. So the O shot is, like I said, it's called the orgasm shot. We inject platelet-rich plasma at the clitoris, which is right over the P tube called your urethra, and in the upper vagina. So I inject it in 2 spots, the clitoris and the 12 o'clock position of the vagina. And what that platelet-rich plasma does is it permeates above the urethra and below the urethra and helps create new collagen, helps wake up some of the nerve cells that may be sleeping. And so you have increased sensation and increased ability to contract your urethra and hold your urine and prevent you from losing urine when you cough or you sneeze.
If you want to cover any more about the thyroid, we didn't really go over that. You talked about the synthroid and versus armor thyroid, but if you want to cover, Hashimoto's, you said you never diagnosed those at all. If you want to cover that, I think some of our listeners might appreciate that.
So it's interesting. So I never diagnosed Hashimoto's until I opened my practice in Illinois and I started following the labs that were recommended by BioTe. And so when you check TPO, and again, as a patient, they don't know what that means, but if you ask your doctor, hey, am I getting a TSH, which they all do, meaning all doctors that check for thyroid, and a free T4, but are they checking a free T3 and are they checking a TPO? Now, anything greater than a level of 9 when you do your TPO indicates that you've got inflammation of your thyroid, and we identify that diagnosis as Hashimoto's thyroiditis. Anytime something ends with the word itis, that means it's inflamed. Now, cause and effect, why? I can easily say to the patient, okay, you're either hypothyroid or you're not, because not everybody with Hashimoto's has hypothyroidism, but if you don't take care of it, eventually they probably will. And so the big question is, if they don't have hypothyroidism, do you treat them with thyroid replacement? Some people say yes, some people say no. I typically do not. I just follow the patient closely. So Hashimoto's, we have diagnosed over 100 patients with Hashimoto's in our 2 offices since last January. So this is April. So in 15 months, we've diagnosed over 100 patients with Hashimoto's. That is unbelievable. And as my wife always says, you don't know what you don't know. If I would have never checked for a TPO, never checked their TPO, I don't think I would have ever identified that they had Hashimoto's. So how do you treat Hashimoto's is not the question you ask. The question is, what caused the Hashimoto's? And then if you ask that question and you delve deep, then if you identify it, then you treat that, and Hashimoto's can be treated successfully and end and not just have it forever. So Hashimoto's is an inflammatory condition where the body is destroying itself. Okay, so it's called an autoimmune disease. Why and how? So we feel very comfortable that the problem is your gut. It's called leaky gut syndrome. And there's a great book called Clean Gut, that you can order on Amazon. And it gives you kind of a walkthrough on how you can treat your leaky gut. There's a very famous MD doctor out in California named Stephen Gundry that has kind of, he's turned, I mean, he was a pediatric cardiovascular surgeon, gave up surgery, and now just takes care of leaky gut syndrome. So leaky gut means that the cells inside your gut have a hole in them. Okay, so think about a wall, a brick wall. Sometimes in that brick wall, they'll put piping so for water to come through, so it doesn't freeze and break down. But if you just have a brick wall, there's no piping in it, that brick wall is there for a purpose, to keep something on this side of the wall from going on this side of the wall. And I'm not talking about jumping over, I'm just talking about, can you get through the wall? Something, though, can cause problems with that brick wall, okay? And over time, cause holes in the wall. That is what is defined as leaky gut syndrome. So now you have holes in the protective mechanism to prevent things from the outside world from getting in your body. What do you want to keep out of your body from the outside world? Well, heavy metals, which are in water, toxins, which are in water and food, antibodies, which are in food. And so what happens is those now get through. The brain in your belly. So remember, you got this brain and you've got this brain in your belly. The brain in your belly says, oh my word, we've got these invaders. They're coming to destroy us. Girls, because we're talking about a woman now. Girls, you guys need to go out and find those invaders and destroy them. So one of these heavy metals gets in your body and goes to your thyroid and gets wrapped up by the thyroid cell because it thinks that the heavy metal is there to help it. So here comes one of the girls that is the soldier to try to destroy the heavy metals. It looks at that toxin that's being held by that thyroid cell and destroys the whole thing because it can't say, hey, thyroid cell, I need you to release the heavy metal. It destroys the whole thing and destroys the whole thing and destroys the whole thing. So you have an autoimmune phenomenon, meaning the body is destroying itself because it's trying to heal itself. So we've identified the cause. The cause is the leaky gut syndrome that's now caused the Hashimoto's. So let's treat the problem, and then the Hashimoto's gets better because then the body takes care of itself. So that's a perfect example of thyroid disease that is a huge problem. Again, 40% of women after the age of 40 have hypothyroidism, but why? And I'm going to postulate, as many do in my world, that it's a leaky gut syndrome problem.
Well, I think as much as we could continue to delve into that and talk about, okay, now what do we do and what do you recommend? I think we will probably end there, and maybe we'll do a video on what the next steps are for those women that have figured out that they have leaky gut syndrome.
All right. Sounds great.
Okay.
Come back and see us. Thank you.